Cardiac arrest. A brutal halt, a betrayal of the body's most fundamental rhythm. It is a stark punctuation mark in the narrative of life, often signaling its abrupt end. Yet, in the face of such finality, there exists a possibility, a precarious triumph, the return of spontaneous circulation, or ROSC. ROSC signifies the reawakening of the heart, a flicker of life rekindled. It is the moment when chest compressions, defibrillation, and the frantic efforts of resuscitation culminate in the restoration of a pulse. This resurgence, however, is not a guarantee of survival, not a promise of complete recovery. It is instead the beginning of a perilous journey, a tightrope walk between life and death. Patients who achieve ROSC remain critically ill, teetering on the brink. Their bodies, ravaged by the insult of cardiac arrest, are fraught with instability. The risk of a second arrest looms large, a constant threat in the immediate aftermath. Organs, starved of oxygen during the period of circulatory collapse, bear the brunt of the injury. The brain, acutely sensitive to oxygen deprivation, is particularly vulnerable. ROSC, therefore, is not an endpoint but a transition, a shift from resuscitation to intensive post-arrest care. The battle is far from over. It has merely entered a new, more nuanced phase. The focus now shifts to stabilizing the patient, meticulously supporting organ function, and navigating the treacherous terrain of post-cardiac arrest syndrome. The moments after ROSC are critical. The body, having endured a profound physiological insult, is in a state of extreme vulnerability. Immediate and comprehensive post-resuscitation care is essential to prevent further deterioration and to optimize the chances of survival. Central to this care is the transfer of the patient to an intensive care unit, ICU. This specialized environment provides the sophisticated monitoring, life support capabilities, and expert medical attention crucial for managing post-cardiac arrest patients. Here, a dedicated team can continuously assess the patient's condition, respond promptly to any changes, and provide the necessary interventions. Continuous electrocardiogram, ECG monitoring is paramount. It allows for the detection of any recurrent life-threatening arrhythmias, which are common in the post-arrest period. Arterial blood pressure monitoring provides a continuous and accurate assessment of blood pressure, a key indicator of cardiovascular stability. Mechanical ventilation is often necessary to support breathing. Many patients are unable to breathe effectively on their own after cardiac arrest. A ventilator ensures adequate oxygenation and ventilation, allowing the body to focus on recovery. These interventions, combined with meticulous fluid management and electrolyte correction, form the cornerstone of immediate post-resuscitation care. The human body craves oxygen. It is the lifeblood of our cells, fueling the intricate processes that keep us alive. During cardiac arrest, this vital supply is severed, leading to a cascade of devastating consequences. Restoring oxygenation is therefore paramount in post-arrest care. Pulse oximetry, a non-invasive method of measuring blood oxygen saturation, plays a crucial role. Maintaining a saturation level above 94% ensures adequate oxygen delivery to the tissues. This often involves supplemental oxygen therapy, delivered through a nasal cannula or, in more severe cases, a mask. Blood pressure, the force exerted by blood against the walls of blood vessels, is another critical parameter. A systolic blood pressure, the top number, above 90 mmHg is generally considered the target. This pressure is necessary to maintain adequate blood flow to vital organs, including the brain, heart, and kidneys. Intravenous fluids, such as normal saline or lactated Ringer's solution, are often used to restore blood volume and support blood pressure. In some cases, medications called vasopressors may be required. These drugs constrict blood vessels, increasing blood pressure and ensuring adequate organ perfusion. However, this balancing act is delicate. Excessive fluid administration can overload the heart, while aggressive vasopressor use can restrict blood flow to vital organs. Careful titration of fluids and medications, guided by continuous monitoring and clinical judgment, is essential. The post-cardiac arrest period often necessitates a carefully orchestrated pharmacological intervention. Medications become essential tools in stabilizing the patient, mitigating further injury, and promoting recovery. These interventions target various physiological systems, aiming to restore balance and function. Epinephrine, a potent vasopressor and inotropic agent, stands as a cornerstone of post-arrest care. It increases blood pressure by constricting blood vessels and strengthens the heart's contractions, improving blood flow to vital organs. The usual dosage is 1 mg every 3 to 5 minutes during CPR, followed by a continuous infusion in the post-arrest period, titrated to maintain blood pressure. Amiodarone, an antiarrhythmic drug, is often employed to suppress abnormal heart rhythms, particularly ventricular tachycardia and fibrillation, which are common after cardiac arrest. It works by stabilizing the electrical activity of the heart, preventing potentially lethal arrhythmias. An initial bolus dose is typically followed by a continuous infusion. Other medications, such as sodium bicarbonate, may be used to correct the metabolic acidosis that often accompanies cardiac arrest. This condition, characterized by an excess of acid in the blood, can impair heart function and worsen outcomes. Sodium bicarbonate helps to neutralize the acid, restoring a more favorable pH balance. Pain management is another crucial aspect of post-arrest care. Patients may experience discomfort from the arrest itself, ongoing medical interventions, or underlying conditions. Opioids, such as morphine or fentanyl, are often used to provide pain relief, promoting comfort and reducing stress. The choice and dosage of medications are tailored to the individual patient's needs, guided by continuous monitoring and clinical assessment. The silent suffering assessing and addressing brain injury. While the immediate priority in post-cardiac arrest care is restoring cardiovascular stability, the brain demands equal attention. Highly sensitive to oxygen deprivation, the brain is often the organ most severely affected by cardiac arrest. Assessing and mitigating brain injury is therefore paramount. Clinical examination provides initial clues. The patient's level of consciousness, assessed using the Glasgow Coma Scale, GCS, offers a basic understanding of brain function. Pupillary response to light, motor function, and reflexes provide further insight into the extent of neurological injury. However, clinical examination alone is insufficient. Electroencephalography, EEG, monitoring is crucial. This technique records the electrical activity of the brain, revealing any abnormalities that may indicate seizures, a common complication of brain injury. Prompt treatment of seizures is essential to prevent further damage. Neuroimaging, particularly brain-computed tomography, CT, or magnetic resonance imaging, MRI, provides a detailed anatomical picture of the brain. These scans can identify areas of injury, such as swelling or bleeding, guiding treatment decisions. Early interventions are key to mitigating brain injury. Maintaining adequate oxygenation and blood pressure is paramount, ensuring optimal blood flow to the brain. Controlling seizures, managing intracranial pressure, and optimizing blood sugar levels are all critical aspects of neuroprotective care. Cold therapy, the potential of therapeutic hypothermia. In the realm of post-cardiac arrest care, therapeutic hypothermia has emerged as a powerful neuroprotective strategy. This intervention involves deliberately lowering the patient's body temperature to a few degrees below normal, typically between 32 to 34 degrees Celsius, 89.6, 93.2 degrees Fahrenheit, for a specific duration. The rationale behind this seemingly counterintuitive approach lies in the cellular response to injury. Hypothermia slows down metabolic processes, reducing the brain's oxygen demand and mitigating the cascade of harmful events triggered by ischemia. It is believed to reduce the release of harmful neurotransmitters, dampen inflammation, and suppress apoptosis, or programmed cell death. Inducing therapeutic hypothermia typically involves specialized cooling devices, such as cooling blankets or intravenous infusion of cold fluids. The patient's temperature is carefully monitored, and medications are used to suppress shivering, a natural response to cold that can counteract the desired hypothermia. While the benefits of therapeutic hypothermia in improving neurological outcomes are well established, particularly in patients who remain comatose after cardiac arrest, the optimal duration and target temperature are still debated. Current guidelines recommend maintaining hypothermia for 24 hours, followed by a controlled rewarming phase. Despite its potential, therapeutic hypothermia is not without risks. Complications such as infection, bleeding, and electrolyte disturbances can occur. Careful patient selection, meticulous monitoring, and prompt management of any complications are therefore crucial. The cardiac culprit, addressing suspected myocardial infarction. In many cases, The underlying cause of cardiac arrest is a myocardial infarction, commonly known as a heart attack. This occurs when blood flow to a part of the heart muscle is blocked, typically by a blood clot lodged in a coronary artery. Addressing this underlying cardiac insult is crucial in post-arrest care. The first step is confirming the diagnosis. An electrocardiogram, ECG, is often the initial test, revealing characteristic changes indicative of myocardial infarction. Blood tests measuring cardiac biomarkers such as troponin provide further evidence. Echocardiography, an ultrasound of the heart, can assess heart function and identify any areas of damage. Once myocardial infarction is confirmed, prompt reperfusion therapy is vital. This involves restoring blood flow to the blocked coronary artery, salvaging as much heart muscle as possible. The most common method is percutaneous coronary intervention, PCI, a minimally invasive procedure where a catheter is threaded through a blood vessel in the groin or arm to the blocked artery. A balloon at the tip of the catheter is inflated to open the blockage, and a stent, a small metal mesh tube, is often implanted to keep the artery open. In some cases, thrombolytic therapy, also known as clot-busting medication, may be used. These drugs are administered intravenously to dissolve the blood clot obstructing the coronary artery. The choice between PCI and thrombolytic therapy depends on various factors, including the patient's condition, the availability of PCI facilities, and the time elapsed since the onset of symptoms. A circle unbroken from ACLS to post-arrest care. The journey from cardiac arrest to recovery is a continuum, a seamless transition from the immediacy of resuscitation to the complexities of post-arrest care. Advanced Cardiac Life Support, ACLS, the protocol guiding resuscitation efforts, sets the stage for this transition. Its principles, focused on restoring circulation, breathing, and electrical stability, lay the groundwork for successful post-arrest management. ACLS emphasizes early recognition and activation of the emergency response system, immediate initiation of CPR, and prompt defibrillation when appropriate. These interventions, crucial for maximizing the chances of ROSC, are inextricably linked to the subsequent steps of post-arrest care. The success of ACLS, measured by the return of spontaneous circulation, marks the beginning of a new phase. Post-arrest care picks up where ACLS leaves off, focusing on stabilizing the patient, identifying and addressing the underlying cause of the arrest, and mitigating secondary injury. The principles of ACLS and post-arrest care are interwoven, forming a continuous loop of interventions aimed at restoring not just a heartbeat, but a life. Early and effective resuscitation paves the way for successful post-arrest care, while the meticulous management of post-arrest patients increases the likelihood of meaningful recovery. This interconnectedness highlights the importance of a coordinated and integrated approach to cardiac arrest care. Certify today on AffordableACLS.com.